The picture you see is the sky from my farm. It's really amazing. And let's see if we can get things going here. We're having technical trouble already. Let's see here. Oh, there we go. I forgot. Okay. There we go. There's the sky, my new dog, Gunny, who likes the swimming pool, obviously. And here's another picture from my farm. Here, this is my favorite horse who lives here too. We have 4 horses, and so they're kind of amazing animals that way. And anyway, here's the first slide. I kind of titled this little lecture tonight, or whatever you want to call it, as "You See What You Know." And my job is to increase your knowledge of the subject matter of biologics, at least one particular one, amnion use anyway, and increase your knowledge so that you see more, so that you can, when you're working with horses or dogs or cats with eye problems and things change, and they always change, part of my job is to increase your knowledge so that you can interpret the changes you see and so you can adapt the therapy. I would encourage you at this point in veterinary medicine, and when you're looking at animals with eye problems, that you photograph every case. You're carrying a phone in your pocket, take a picture, and then as part of your exam, look at the picture. Because like you see in this picture here, there's blue, which is edema. There's a dark spot. It's got a little white spot reflecting in the center. You wouldn't see this in real life, but you can see it in the picture. We also see blood vessels here. We got a whitish area. We got a cellular infiltrate. But that little spot in the center means this eye's leaking. There's a hole there. It's a little tiny hole, but it's leaking. We're going to come back to this case later, and I'll show you what I did with it, because this was a wonderful horse. Clients had no money at all, and they're at the university, and we're not cheap. And so how did I handle an economic case where you got a hole? I'll show you. Okay. But it's time to get in the habit of photographing everything. It's an essential part of what I do. You see my phone number's up here if you need to get a hold of me. There's one way to do it. There's my email address. People write me every day. If you write me, I'm going to ask you to send me a picture. Even if it's a bad picture, just do your best, right? Let's see here. Next one. This is part 2. We had another lecture with Tilltop, and this is the second one, and we're talking about the ocular surface. We're talking about bad problems, I guess. And I want you to be aware of this case, because this case changed my life. The reason I'm here tonight is because of this horse. It's because of this eye. This was 1999, and I was at the University of Florida. Obviously, I had been there since had come back in 1990, and so I've been there 9 years, and I was learning. Florida at the time was a tremendous place to be as far as knowledge. We had all these PhDs and MDs, and we all worked together. And it was, when I look back at it, it was really a golden time for me. There were just so many people to learn from. Anyway, so this horse has a melting ulcer. Okay, the collagen it was infected. The collagen in the cornea is degenerating, liquefying, and it's not just a 5 millimeter area. It's not just a 10 millimeter, 1 centimeter circular melting ulcer. It's the entire cornea. I didn't know what to do. I didn't know what to do, because I knew that if I did anything surgical, which is what the textbook said, I knew that I would blind this horse with a scar. I wasn't so much worried about infection or controlling it. I thought I could get that under control, and I did. But I didn't know what to do. How do I handle all this liquefaction? So I did what the book said, and I did what's called a hood flap. And this is like 6 weeks after, and the horse is not painful, and I mean, and he holds his eye open, but he's blind. Now, there's a little clear area you see on the right part of the limbus, a little bit. The owner was convinced this horse could see something. I learned a long time ago never to argue with owners about whether the animals could see or not. I just go by their opinion. I guess I'm sometimes bothered if I know they can see and the owners think the eye's blind or whatever, but still, I just don't argue with them. It's their perception. But this horse did have a dazzle reflex, but he couldn't see anything. You know, he could see light, but he couldn't see images. And I don't know, any of you know me very long. I don't like to fail. And I consider this a failure. This was 1999. A number of years later, I tried to find this horse to see what the scar looked like. And I mean, you can't cut this flap off. This is called a hood flap. It's actually in the literature as an appropriate therapy, and it just wasn't. It just wasn't. So I started looking for options. Here's 6 weeks later. Sorry. Here's the. I mean, it just doesn't. After 6 weeks, it's not on any medicine anymore, and I didn't know what to do, and so horse was not painful. I sent it home. You see what you know. I didn't know enough. I didn't know how to adapt what had happened to what I saw. If things changed, you see in the second sentence, they changed, but I didn't know what to do. Tonight, we're going to talk mostly about what happened because of this case. We'll get to that real soon. But what happened was I found another option. The thing is, in what horse ophthalmology is, I am always, and I'm going to assume you are too, whatever's happening clinically, I'm always late. It's always happened the day before, and then the owner brings me the case. Or, I mean, I'm always reacting. I can't be proactive. I'm reacting, and sometimes I panic. After all these years, I still panic. I don't know what to do. So I've learned to look at panic with some creativity. You know, it's energy. Panic is energy. Use it to think and think about what can be done. Now, here, this next sentence seems obvious, but it's taken me 30 years to figure this out. And I knew from the beginning that, well, at Florida, I was told initially that the horse eye heals poorly. That is not true. We found out the horse eye heals really well. It heals really slow, though, and that is another generation is going to be their task to figure out how to help it heal faster. But it has the diseases that attack the horse's eye are some of the most disastrous, destructive in all of comparative ophthalmology, all species. I mean, it's just amazing. But the first sentence there you can see in all capitals is something I learned probably 20 years ago or something, maybe even 10. It wasn't right away. It was a long time. And that is this. When the horse's cornea is injured, even slightly, if any of the cells or the tissue are damaged or destroyed, the horse responds by sloughing out those cells. So a tiny little corneal abrasion becomes an ulcer because the damaged cells, the horse gets rid of them. That's how they respond to healing. That's what you and I have to understand. And you'll see in my pictures, you'll see that you have to react to this because you can't stop it. How does a horse create a desmetacial? They're really good at it. Real good at it. Why do they do it? Because everything anterior to descemet's membrane was injured, was damaged, and the horses get rid of it. You can't stop that process. Okay? But we have to. My point is, it's like in order to help the horse's eye heal, we all need to understand what the horse is trying to do itself so we don't get in the way. We need to help it if we can. And tonight is a little bit about that. Just some other things I learned here just before we get into this. I learned from one of my residents, Todd Struby, in the late 90s. My residents always at Florida, I had 30 of them or so, and they were wonderful people, and they taught me so much. I hope I taught them something, but they sure taught me a lot. And Todd did a research project looking at tears at the tears of horses that had corneal ulcers, and he found out that the enzyme levels, the proteases in the tear film, were dramatically elevated, and that was surely something that changed the medical standards of care, because we found out that if a horse has an ulcer, in order to get that ulcer to heal faster, we had to control the enzymes that were in the tear film. If we couldn't reduce the enzyme activity, it wouldn't heal whether that was infected or not. Sterility did not guarantee that the ulcers were going to heal. So ulceration often proceeds in spite of using effective antibiotics. Sure, you can kill the bacteria, you can kill the fungi, but the enzymes are still there. So what we learned from Todd's work is that combination of antibiotic and protease inhibitor therapy, no matter what kind of protease inhibitor, was going to improve our clinical results. We learned that pretty early, but that was a big deal. What I see every day, and I feel it in my own heart. A horse has an eye problem, and it's not getting better. Okay, and so if it's an ulcer, then what everybody does, what I see in my referral practice, and what I feel in my heart is, if the horse has got an ulcer and it's not healing, then the first thing we all do is switch the antibiotics or the antifungals. We switch them, but that's not always the case. I would argue that most of the time we don't have trouble sterilizing the ulcer surface, sterilizing the ocular surface where the ulcer is, sterilizing an abscess underneath an intact epithelium. We don't have trouble killing the fungi, I would argue. The problem is we can't control the horse's reaction to these organisms being there. We can't control the reaction to the enzymes. One thing to notice, you see in this eye, we got a horse that's got hypopyon, and there's so much confusion about hypopyon. Let's just stop it right now. Hypopyon does not mean there's infection. It's just an extreme form of uveitis, and I don't really care as long as if I get work on a horse who has hypopyon, and I institute therapy for the ulcer that's causing it or the uveitis that's causing the hypopyon, as long as the hypopyon goes away or starts to go away once my therapy started, I'm good. If I start to initiate therapy and I get more hypopyon, something's wrong with the therapy. Okay, hypopyon is just something you'll watch. Pupil size is something you watch. It gives you information. It's not critical in its own self. It's just telling you whether your therapy is going to be effective or not. Large, deep ulcers. If I have a horse that's got a really bad ulcer and a large size and it gets deeper and the blood vessels are coming in, I'm usually happy because the blood vessels are going to bring plasma into the area and help clean up the ulcer. However, if there's a lot of vascularization, there's going to be a big scar. Now, with time, that scar will diminish, but initially it's going to be a big scar. Be ready for it. Anticipate it. The other thing too is horses are really good at hiding the severity of their eye issues, and so it's like when the horses are getting better, no matter whether it's uveitis you're treating or whether you're treating horses with ulcers or abscesses, when the eye's getting better, wean them off the medicine. Don't just stop stuff. They're good at hiding it. And if you're worried about infection, slow down, wean them off the antibiotics or antifungals first while you keep up the uveitis therapy. But just wean them off. I've learned the hard way too many times that the horse's eye was not as good as I thought it was. Deep ulcers, well, why are they deep? A stupid thing, but this is critical to understand this. A deep ulcer means there's collagen missing. And I learned from my own cases, working with one of my residents, Mikola Henriksen, who's now at NC State. Mikola showed, looking at Florida's cases of horses with iris prolapse, that replacing the missing collagen doubled our success rate. I mean, that seems obvious, but it wasn't obvious for a long time. Deep ulcers need more aggressive therapy, more frequency of administration. When you have a deep corneal ulcer, you're really dealing with two eye problems. You're dealing with the corneal problem and you're dealing with uveitis. But the horse is really good at compartmentalizing the uveitis. You always think of the horse eye as having a front half and a back half, an anterior part and a posterior part. You can't see the posterior part. You can only see the cornea and all the disaster that's going on in the anterior chamber and iris, okay? But it's so important. It's so important to evaluate the posterior part of the eye. And how do you do it? You do it with a dazzle reflex. The very first thing I do when I look at a horse with an eye problem is check his dazzle. Every time. And I'll show you some videos here in a little bit, but about how to, like somebody said once, what if the horse is squinting? Well, how do you evaluate the dazzle? I'll show you. That's a great question. Also, the other thing the early textbook said, if the horse has a really sick cornea, a lot of inflammation, that they'll have severe uveitis, and that's not necessarily the case either. So here's my own horse, and here's a dazzle. I just walked up to her, I shined a bright light at her, she squints. It's also called light perception, okay? It's a big deal. The books are wrong all about what this means. They have to see this, okay? And if you want to test the retina, this is how you do it. I don't care what the books say. They have to see this. They're perceiving it, okay? This is what you're looking for in an eye that's really sick. Does he have a dazzle or not? What if they're squinting? This horse is squinting. Well, without doing a nerve block, just gently open his eye and then shine the light up. See him squint. If he's squinting, you can still evaluate the dazzle reflex, okay? You got me? I'm going somewhere else in this lecture, but I'm starting with this to make sure we're all in the same wavelength here. We're all thinking the same thing. Now, here are just general comments about treating corneal ulcers. General. We're going to get a little more specific on most of this stuff. This is the medical standards of care. Sterilize the ulcer surface. Now, I try to base this myself on cytology, which I do myself. Culture, yeah, sometimes, but not. It's expensive. I don't always do it, but I do cytology and I look at it myself. So we want that's important. It's critical. It's also critical to reduce the enzyme activity that's in the tear film and in the tissue. It's part of the medical standard of care. How you do it is your own way, and there's all kinds of little tricks and things to do to get this done. If there's corneal edema, we may have to. I got it listed as number 3, but I'm not so sure that it's that important. But I just listed there, and a lot of you, when you're out there seeing horses with eye problems and you see edema, I know, shall I use hyperosmotics or not? Well, I understand. Every horse with an ulcer or abscess will have some degree of uveitis. They need atropine. And don't tell me that you're going to give the atropine to effect. What effect are you talking about? I know what you're talking about. Till the pupil's dilated. Well, okay, but atropine does 3 things. It dilates the pupil to reduce synechial formation. It also helps with eye pain, some horses really significantly. And the third thing it does is it helps get rid of the flare. It makes the iris capillaries stronger. And that's really important in eyes with uveitis. Also, replacing the missing collagen. If it's a deeper ulcer, I found out in my own cases that replacing the missing collagen sped up the healing, and also I got a better, less of a corneal scar, so they saw better. How do you do that if you're not going to do surgery? I'll get to that tonight. How do you replace the missing collagen? Can you do it without doing surgery? Yes. And then the last one's sort of in the future here. And yet the future is really close to being here, whatever, as silly as that sounds. Reducing the scarring. The horse will do it themselves. They're really good at it, but none of us are patient. I'd really like to see that first horse that I showed you in 1999. I couldn't find. The owner couldn't remember what he did with it, and so it's like, how can he remember? He couldn't remember what he did with it. But anyway, that's what he said. I'd really like to see that 10 years later. But I don't. But I bet it's still pretty scarred.
Dr. Brooks, we have a question before we keep moving forward. Was the horse with the, I'm not going to say it right, blepharospasm sedated when testing the dazzle?
Oh, read the sentence to me again. I'm sorry.
It's in the Q&A, but it was the horse sedated when testing the dazzle.
Oh, yeah. They can be sedated. They can have a dazzle. I think that horse probably was not in that video, but it's still, they'll respond. You're not going to sedate them that much. You need a bright light. You need a bright light. Yes, I don't know. If you're not sure, test them. And check the normal eye and use that as a control. I don't, unless they're falling down, I think they'll still have a dazzle. So level of sedation, I don't think is critical. But that's a good question. We now have the ability to help here. The process where the horse heals its cornea and reduces all the cells that are there, eliminates the vascularity or the perfusion of the blood in the blood vessels. That whole process, when they build new collagen, is called remodeling. And now we can influence that now. And so here's the thing, some of the things we're going to talk about tonight. Not all of them, some of them. I mean, we're going to talk about something called flowable amnion, which is liquid, which is an eye drop amnion. It's a big deal. Amnion discs that were freeze-dried, I'll show you some pictures of them. I mean, I use them all the time. Some of you will or won't, but I mean, they are very, very useful as well. Replacing missing collagen. If there's a deep ulcer, then replacing the missing collagen is really important to getting the cornea to heal faster. Hyaluronic acid topically is very beneficial. Collagen cross-linking, we are not going to talk about tonight. We did last time, but that's something that practitioners can and should do. Where it's basically putting vitamin B2 on the cornea as an eye drop, and then shining a UV light, which you can. I'll show you where to get this. If you can get it from Amazon. Well, you can't get the riboflavin from Amazon. So you get the lights from Amazon. They're $45, and it really helps. And cyclosporin, many of you have been using. Cyclosporin has anti-fibrotic activity. So Wendy, and I'm going to start. Hilltop asked me to do a couple of things, and I agreed to do it because I thought it was reasonable. And then we're going to look at specific cases. Okay, if you're going to use amnion, when do you use it? Well, if you think you have an ulcer, and it's whether the flowable type, the flowable is the liquid, it's an eye drop, it goes through a lavage system. Use it now. There's no waiting. The discs, maybe you wait, and I wait, even wait until it deteriorates somewhat, that the owner is convinced to have surgery. But the flowable can be used now. If a corneal ulcer in a horse, a 5 millimeter diameter ulcer should take about 5 days to heal. It's a millimeter per day is how fast its cells migrate. If it's slower than that, then it needs to be investigated. I know what most of you do, and I know what in my heart I want to do is I just want to switch antibiotics. If it's slower than that, I'm going to see some horses tomorrow, and that's exactly the situation we're in, where the ulcers are just not healing. So what am I going to look for? Well, I'm going to do cytology and see if a new bug has shown up, or do new. But I'm also going to look at the tear film quality and any extra eyelashes or foreign bodies or whatever. We're going to look for things. If the ulcer gets deeper, we're losing tissue. Definitely get cytology and plus or minus culture. If you see a groove, I'll show you what a groove looks like. A groove is when a horse is starting to form a desmetocele. That's scary. Horses are really good at forming desmetoceles. They need something more than just, let's call it traditional medical therapy. They need adjunctive therapy. If the uveitis increases in activity with an ulcer, then there's something wrong with the healing, again, of the ulcer. This is a groove. This is a furrow. It's a dark ring around a circular ring that surrounds an ulcer. The whitish area is neutrophils, is a cellular infiltrate. The horse is going to slough this out and form a desmetocele. You can't stop it, but you better be aware that it's going on. It took me a long time to figure this out, okay? And I did it. I lost some eyes, but now I know. This horse might benefit from surgery, but at the very least, it definitely benefits from an increase in the frequency of drug administration. Here, one thing to know: if you put an eye drop on a horse's cornea, if you put an eye drop or ointment on a horse's cornea, it's only there 7 minutes. So you better hope it penetrates, or the owner gets plenty of medicine in there, or it gets absorbed quickly because it's there 7 minutes, and then the tear film just flushes it out, which is a scary thing to be in when you see a groove. So let's just get into a little bit of that's the scary part. I guess I'm trying to scare everybody and probably succeeding. If we have a really sick cornea, what are our options? Okay, let's call it corneal surface. The ocular surface is the conjunctiva and cornea and the tear film. And what are our options for reconstructing or helping the horse preserve it and reconstruct it? Well, when would we need to do this? Well, bad ulcers, deep ulcers, melting, and secondary to squamous cell. The purpose of reconstruction is replacing the missing collagen, getting rid of the infection and any melting activity, the pain, and trying to get this thing to heal without much of a scar forming, which would be nice and not always possible. Is this a superficial ulcer or deep ulcer? Is this a superficial or deep? Dark is thin. This is a deep ulcer. I didn't get this one better. I'm still pretty angry about it. I should have been able to, but I didn't. For replacing collagen, there's a whole variety of things done over the years, and I just want to mention a little bit. It's amazing. The Brazilian veterinarians have been led the way in this. They're really fascinated by this, using horse pericardium and the amnion, peritoneum in dogs, which has been used. Equine amniotic membrane. I think the Brazilians may have been the first people to do that. Renal capsule, porcine, small intestine, submucosa, and a variety of people have done that. But I mean, there's been a variety of things looked at to help the horse with a really sick cornea. And it's amazing to me. I started working with amnion in a big way in about 2003. Took me a few years to educate myself about what was going on, and then we started with that. And there's a variety of companies and sources of this. And there was a time that I was supplying in Florida. We were supplying the whole United States with anybody that wanted horse amnion, and they could use it in whatever species. And we just charged them the shipping costs. Some of you probably took advantage of that. And other ones like, where was I when I was doing it? But I mean, we did it and got a lot of good clinical data out of it. And we found out, at least initially, that amnion in a disc form, which is a freeze-dried product, at least it was initially, was something we needed to investigate. We were also using cornea, and I started my own cornea bank. And we did a tremendous number of corneal transplants in horses successfully, and had all kinds of good experiences, mostly good, but some bad. We learned a lot. And we kept coming back to amnion, though. And we were doing corneal transplants, I call them by themselves. And then we started covering up the transplants because we were having trouble with some of the healing. And sometimes we covered up with conjunctiva, which seemed ludicrous to me, why. And then also, but we did it. And then we started using corneal transplants with amnion. And the amnion we got better results with the amnion than with the corneal transplant by itself. And then we started looking at it. People started studying this, and we did too. Not the amnion discs, and we tried other things too. They're listed here. But we just kind of, our results just seem to be better with the amnion. And so we were using horse amnion in dogs, and other people were using horse amnion in cats, and there didn't seem to be any rejection issues like that. And what we found out was this: no matter what species we use the amnion discs on, initially, I don't know how you looked at this, but when I would have challenging problems in the clinic with corneal problems, I sometimes asked my physician friends for help, and they were always helpful and interested and provided lots of ideas, and they were always wrong, you know, but I thought, well, okay, I still like these people. I'll talk to them anyway. And so their advice was usually wrong. And what they said is that the amnion, we want to use it as a graft, but we didn't want to use it as a graft. We wanted to use it as a bandage. We wanted the amnion to fall off about 7 to 10 days after we put it on. It provided a scaffolding. I'll show you that in a minute for the epithelial cell migration. It also contains collagen, fibronectin, which is critical to healing of corneal ulcers in horses. Where do you get fibronectin? Well, plasma, number one, is a place. Hyaluronic acid, chondroitin sulfate is part of the normal horse corneal stroma, and so amnion contained all these things, and there didn't appear to be any rejection, and it was a replacement for collagen, as I mentioned, but it also did something quite unique that was really important to the horse, because at Florida, we had always been saying if we could just help this animal heal, if we could do something to give this animal time, it could heal. And so what we found out is that this amnion seemed to be an ideal bandage or disposable dressing, and that the fungi would attack the amnion. The proteases that were attacking the cornea would attack the amnion. The bacteria would attack the amnion, and that gave the horse time to heal. And then the amnion either falls off on its own or we cut it off. So we'll see some pictures of that. Here's one picture of amnion on a horse's eye, and you can see the vicral sutures. So this one's sutured on. Many of you aren't really that interested in using amnion or anything else. You're not interested or don't feel capable of putting sutures in. So we started looking at other options too. We'll get into this too after a little bit. And that's glue. Using various kinds of glue, taking the disc and putting the glue on the disc, and then putting that on the cornea and gluing it. And we'll come back to this again as well. So they can be sutured or glued on. I'll talk about this case later. This is the very first case I showed you. It had the horse with a deep ulcer and had a little shiny area in the center, meaning it was leaking. This is the glue on this horse. Well, I'll show you all of them again. So amnion itself can be glued or sutured into place. It can be, we've attached stem cells to it and put that on the horse. We're not doing that at the moment. So I think some other people may be. Amnion can be freeze dried. It can be used right off the placenta. I mean, fresh. C-section is preferable, I guess. We'd always heard, though, we always wanted to know, and we learned very early from some of the amnion people that there were ways to take the amnion and turn it into a homogenate or a liquid. It's called flowable amnion. And so these people really helped us, and that's kind of why we're here tonight. Because some of you should be really interested in this, because it's available and it works and it's available. You just have to have it. Now I wrote down here: is amnion used adjunctive therapy or not at this point? Because many of the biologics, on my mind, are. I mean, directing. What we're trying to do is get help the eye heal, so we get rid of the infection, reduce the enzyme activity, we treat the uveitis, we treat the inflammation as best we can. And is it adjunctive therapy or not? The jury's still out on that, I guess, but it's surely becoming a point of where this tissue is so useful to me that I use it in nearly every case. Now, just a little bit more about amnion itself. It's a self-sacrificing dressing. We put it on as a bandage, and we want it to fall off. I'll show you why in a minute. My physician friends who are the leading researchers on this and people, they said, well, you want the amnion to stay on. It's very strong tissue. It's very thin. It has anti-inflammatory properties. It also has attachment factors that help the cells that are going to cover up the damaged cornea, help it heal. It has a lot of anti-protease activity. And it has anti-fibrotic powers or capabilities. It also acts as a sink, I guess is the term. That it attracts the bad things, the enzymes and the bacteria and fungi, and they attack the amnion and gives the horse time to heal. Here's what amnion looks like. It has a basement membrane side and it has a stromal side, okay? And here's just what it looks like when it's out on a piece of paper. And then people have this, they get so worried, well, if you're gonna put the amnion on the eye, how are you going to, which side goes up? Which side goes down? You know, if you want it to stay, if you want to try to get the amnion to stay there, which I found out most of the time you do not, but if you want it to stay, then you put the stromal side down. But if you put the basement membrane side down, it'll just fall off in a week or 10 days. Yeah, it's just a thought, but it's very strong. So this is a part of the amnion that fell off, okay, of a horse. And the stromal side is over here on the right. This is the part that's away from the cornea. Now the tissue is folded on itself. I guess I should go through and edit this and see the part on the right, the far left side of the picture is folded over. But this part where all the purple stuff is, I remember from histology in vet school that purple and histology sections are bad. Purple is a bad color because this is, look at all the hyphae and neutrophils. This part in here, this was up against the cornea. And then it falls off, which is good. You let it fall off, you know, it's bad. Here's more hyphae, perfect hyphae. This is amnion. This is what it's doing. It's being attacked, which is a good thing. The part that you want against is the basement, is the stromal side. But I don't know if Hilltop or any of the other companies that have this capability. I'd be interested too. They can jump in later and say, "Do you know which side's up on these?" I don't think it matters, but it theoretically might. We looked at the proteomic analysis of the equine amniotic membrane in 2014, I think, and it was funny, all this high technology stuff, and this is what it looks like, which like a bunch of dots, right? And then you get this computer readout of all these things, and but we did find out what's in it. And so these were what I mentioned already, that it has adhesion factors, and it helps the collagen fibers line up properly. It has collagen in it and all this other stuff. So there's good science behind this that's not present in other things. So okay, before we look at cases, Hilltop wanted me to, and I did too. They want me to say, well, what are the results of amniotic membrane therapy? And I saw it. I think it was 2009 or something. We published. Karen Plummer was the first author. 58 cases, and these were bad ulcers. We weren't doing amnion. These were sutures, sutured it on. In 69%, we had a real, the scar was barely showed. Sometimes 24%, or so now we're at 73%, or 93%, I guess. We had a little bit of haziness, which is tolerable, but then we still lost a few eyes, which we weren't getting easy stuff. I just want to emphasize one thing: no matter what therapy you use, adjunctive, traditional, traditional Chinese medicine, whatever therapy you use, treating a horse with a bad eye problem, it takes a lot of work. There's a lot of work went into these 58 cases. My residents were with me at the time, I'll tell you. I mean, we worked hard. The owners worked hard. So horses with severe eye problems are not cases you can walk away from. Some veterinarians don't like to deal with them. I understand that. I don't like to lose. So even after 42 years, I'm still kicking it. You know, I want to win all of them. I want these horses to see. So this has helped that. These are two of the products that Hilltop's got. This is the I don't know what they call it, but this is the liquid form, and it's a homogenate, is what the amnion scientists used to call it anyway. And then here's the discs. You know, the round disc, and they come. I think these are 25s. I don't know if they make a smaller one or not, but the discs have to be sutured on or glued on. We'll come back to that. But this is just an eye drop. You know, when I get an ulcer that starts misbehaving, if it stops following the millimeter per day healing rate, they get this stuff. I don't wait anymore. There's no reason to wait. Well, it can be here's a membrane. If this one's sutured, I mean, I have that option, you know, to suture. But I learned not all my clients have. Not all my clients can afford it. Laying the horse down, and it's not easy to put in too many sutures in a horse that's standing up. But there are a lot of options now using amnion, so I think you might find them useful. So this is the first one.
Dr. Brooks, I'm just going to interrupt one. We had a question about the glue that you use.
Yeah.
I thought we would just get into it just now, but we kind of glazed over it. So now we've got a second question. What kind of glue do we use?
Well, there are several veterinary tissue glues. Tissue Mend Room, I'll show pictures of this later, but Tissue Mend Roman numeral 2, Henry Schein used to have this really good stuff called Vet Close, and they took it off the market. And I was so angry because of, like, this stuff really worked. So you'll see they have a new one now. But Tissue Mend Roman numeral 2 is a good one. There's another one called Gluture, G-L-U-T. I'll show pictures of all these and have the names up there for you. What's another one? Covitris is another one. That's Henry Schein sells that. There are veterinary products. I wanted to get into fibrin-based tissue glues, and I've not had good luck with that. Somebody asked a question before the meeting tonight about using platelet-rich plasma as a glue, and I have not much experience. It was a long time ago, and I probably should start it again. But I'm using cyanomethyl methacrylate glues at the moment. Are they perfect? No, but they can really help, and they keep the glue. Yeah, they keep the amnion intact. This one, I'll come back to that, Amanda, too. But this is. I remember this was 2003. So it took me 4 years to start to get organized here. 99 was the horrible case I started off with, and then we're looking at this horse, and it's a mixed. It's a Pseudomonas ulcer and fungus in both. And I didn't know what to do. Again. And my resident was a first-year resident, very smart guy, but very inexperienced, and said, well, why don't we do an amnion graft? And I thought, okay. So we did. Anyway, so what we did a 2-layer. Now, you'll see that I've got in my head that my results are better when I do 2 layers of something. Whether it's 2 layers of conjunctiva, 2 layers of amnion, 2 layers of porcines, mucosa, small intestinal cell. 2 layers. And so here's the ulcer here. It's a melting ulcer. So we did a keratectomy and just real easy, just remove some of the superficial necrotic tissue, because if we didn't remove it, the horse is going to have to. And we put on a single layer of amnion, and then we covered it up at the limbs. Why do we do what do I think the second one does? I use vicryl sutures, and the second layer protects the sutures. And we continue the medical therapy. People say, well, do the antibiotics go through the membrane? Of course they do. How could they not? That tissue is not normal. There's no barriers to anything. Everything penetrates at this point. 2 months later, he's off medicine. This is really classic stuff of healing amnion ulcers. You get this central axial ulcer. So here he is, 2 months post-op. A year. I got to see him at 5 years. I got a picture of 7 years. I mean, the flash from the camera makes this a little bit more prominent than it is, but I mean, he's got a little haze. But this is what I was looking for, a chance. The owners of this horse are quite famous people, and I won't mention their names, but they bought this horse to replace their other favorite horse, and so he gets a really bad ulcer. Look at all the melting activity here. So much edema and necrosis that you can't see inside the eye. We did membrane graft. I don't have a picture of that, although you can see how shiny the amnion is. See, look at the flash from the camera here. No amnion here. Anyway, so and this is when I learned about I didn't want the amnion to stick. I didn't want it to adhere. So let's see here. I go back here. Where I can't read the date here now, but we're somewhere 11/4, the 4th of November, and then we come and here's a week or so later. The amnion's falling off. It stains with fluorescein dye. There's an ulcer here, and you can see it. Here's the amnion. It stains. So we keep up the medical therapy. Oh, there's another one. Same time period. Same time period. And then a week or so later, the ulcer is getting a little smaller, but this is amnion. It's still there. It's not going to fall off. And I didn't know enough to cut it off. And then it's all healed. A month or so later, look where the scar is. Where the amnion stayed, it's got a scar. Where the amnion fell off, it's much clearer. And then I made a phone call to Miami and asked the doctor I was working with at Bascom Palmer. I said, what's the deal with that? He said, oh, you want it to fall off. I said, thanks for telling me. Now we cut them off. I don't leave it there. Well, usually they fall off. Here's another one. Here's a Pseudomonas ulcer. Nice circular ulcer. A little dark in this, a little thinner there. It was trying to heal, but it was going we're not happy. We covered it up with amnion, put some collagen on it or in it, and then covered it up. And here's a month later, goes off medicine now. 6 weeks. It's really, these are suture tracks, and the amnion lead. You see these tracks. And I'm not sure I know what that is. You don't see it with conjunctival grafts as much. I'm not so sure I understand why that is, but they become very small with time. Here it is at 10 weeks later. Looks pretty good. Sneaky bunny. This was a beta strep. Now, beta strep is the worst organism to attack the horse cornea. I mean, it's just horrific. Much worse than Pseudomonas, much worse than any fungus I can think of. Beta strep is just evil. And that's what this is. So she gets a double layer of amnion. See, now you can really see it. Here's the inner layer that's sutured. The outer layer is to protect the inner layer. And you can put a continuous suture around the outside. You can do it real quick. This one takes time because it's simple interrupted, but this one's pretty quick. So this is on December 23rd. 5 days later, the outer one's fallen off, which I kind of didn't like so much. Now the inner one's starting to fall off. Here's the bare cornea. Look at the vascularization. And a few weeks later, now we're done. but we got this central area with the suture tracts. And then when I was preparing for this lecture, I found this one. Pardon me. And a little asthma cough here. Pardon me a second. There's an enterobacter, but look at God awful, this thing's ugly. And pardon me again, sorry. I got more amnion here, slightly out of focus. And after a few weeks, I got a whole series of pictures. And it was really an adventure getting this one to heal. And but it got a little bit more scar than I would have liked, but I'm sure this was 2010. I'd sure like to see it now. We also started doing dogs. And this was a dog that got bit in the cornea by a snake. It's the whole cornea is melted. Not just 5 millimeters. This is everything. This is the catastrophic cornea. So here's the amnion being sutured in place. There's a week post-op. Not real pretty yet. It's got a good dazzle. 2 weeks post-op, everything's fallen off. This is 5 months. I mean, I think anyway, here, look. That's look pretty good. I mean, it's got a scar, but this dog can see. He holds his eye open. The owner's happy, and I mean, we're happy. I'd like to see it now. This is 09. So eventually, we actually started doing this ourselves. Somebody told us how to make the homogenate ourselves. I'm not going to tell you how we did it, but we wanted to try it. So because we want to use it through the lavage systems, and it seemed like it was very beneficial. And sometimes we could avoid surgery, and sometimes we couldn't. But we went ahead, and we could even use it subconjunctivally. Now, this is a subconjunctival injection. I think it'll play. I have done more subconjunctival injections of various substances in the last 2 or 3 years than in my whole 40-some-year career. And one of the things I inject is flowable amnion. The other thing I use is if I want to do anything to the horse's cornea, I give subconjunctival lidocaine or carbocaine or bupivacaine, whatever. I don't think the topical and the ophthalmic anesthetics, I don't think they work very well in horse, and they need the lidocaine or the carbocaine that you use to give it a nerve block somewhere else in the body. They need that topically. It doesn't. They don't work as fast as the ophthalmics, proparacaine or tetracaine, but they sure work better. And I do this routinely now. And the owners like it, and we're giving some treatments for uveitis that we're not talking about tonight. We're giving that subconjunctivally, and the horses come in and get it every 2 weeks, get a shot, and things are getting better. So there's good things happening in equine ophthalmology. We don't have time to talk about tonight, but we're going to do subconjunctival injections. Some of you are probably anyway. This is one of the horses we saw recently. This is here's a front view of it. And look at the side view. This is a really sick eye. And then here's what it looks like with fluorescein. So that's on the flowable type. Here's just another same pictures we looked at just closer. Same day, same picture. It's got a little thin area. Dark is thin. Dark is still thin. And let's see, a month or so later now I don't like it's still a little bit, the ulcer's healed. I don't like the scarness, but I'm pretty sure that will go away. And but we got this was without any kind of surgery.
Dr. Brooks, there is two questions.
Go for it.
One is from Dr. Herman. Are you following up with DACVO or CSA weeks or months down the line to try and decrease scar tissue or pigment? Thanks.
That's a good question, Jamie. I haven't done tacrolimus much, but I sure have done cyclosporin. But my experience, though, is you have to start it early. We've been using a drug called rapamycin or sirolimus instead of those other two drugs and giving it subconjunctivally. And that seems to, it's been hard to get, but I found a source of it. And that seems to be really helpful. But you know, Jamie, Mother Nature takes care of these scars. I mean, it's amazing. I mean, look, I'll show you this case right now. But I mean, it's amazing what time will do. And none of us are patient. The owners aren't patient. We're not patient either. But that's why I'd like to see that very first case. I'd love to see that case that I saw in 1999 that started this whole thing for me. I'd really like to see how bad it looks or good.
We have two more questions.
Jamie, it would be clinician's preference to do it. If you think it helps, I'd sure like to know. What's the other one, Amanda? Or was that it? Did you get two questions?
So we have Dr. Buchanan said, do you have to cut off the glued amnion, and if so, when? And when do you cut out the sutured one?
It just sloughs. It's really attached. I got a couple of those. I'm afraid to cut them off or do that, and so I kind of let it slough without any kind of therapy. They can take care of it. What was the second part of your question, Amanda? What did Ben say?
And then what do you cut out? When do you cut out the sutured one? I think that was the.
Oh yeah, 7 to 10 days post. You probably 10, a little bit, but yeah, I'll trim them pretty early. Yeah, that makes a difference.
I'm gonna let Dr. I'm sorry, I'm gonna mispronounce your name, but Molin or Moline, if you would like to talk, I'm gonna give you that access, and you can ask your question.
I know you. I think Jenna. Are you? Oh, she's muted. Oh, now you're.
I don't know why it's asked me to have. I'm enjoying the presentation. I didn't have any questions, so I'm enjoying listening.
Oh, you just well, thank you.
I don't know how it said that I needed to ask a question. I don't know what I must have hit.
There you go. You did good. Anyway, let me just talk a little bit about another option for surface reconstruction is what to do with. You have a corneal squamous cell, which I like to see because of all the squamous cells on the squamous cell on the eyelid, third eyelid, or cornea or conjunctiva. The cornea is the best one to get as far as you can really getting rid of the thing and having it not come back. Third eyelids can be really bad. Eyelid, because the blood vessels can be bad, can be difficult. But the cornea is a good place. Conjunctiva may even be better as long as it doesn't get deep. Anyway, so I got this horse named Scribbles, and it's a white pony, and it's down here in Florida, and it never goes outside in the daytime. It only goes outside at night. It's in a bar and the rest. It's very well taken care of. And so over the years, he's gotten squamous cells on his eyes, and so we were allowed to treat them differently. So the very first one was in the right eye, which is I don't know if I'm showing which one first, but let me show you what happened. On one of them, we did a keratectomy, and then we did radiation therapy. And then I learned really quickly that if you do radiation, you need to cover up. You don't want to have an ulcer. So you cover it up with conjunctiva. So we did. You'll see that how that works. The second eye, we did a keratectomy and radiation, and then we did amnion. It was our control. Okay. So here's the bad squamous cell, but it came right off, and you can see that here's the amnion that's glued on. And let's see here. Here's the right eye. Here's the first one. This is the squamous cell. Here's the one on the left eye. I think this one we did first, and so it's going to get the. This is a conjunctival graft. It's 3 years later. It looks like the tumor came back. This is the amnion eye. Now both these eyes got keratectomy, both of them got beta radiation, and then this one got covered up with conjunctiva, this one got covered up with amnion, and I think this was 2.5 years later or something. And which do you like better? I mean, to me, the amnion left a much smaller scar, so this kind of reinforced my idea at the time. Richard McMullen at Auburn sent me this video, and this he had an amnion that's the graft is sutured in place for a superficial non-healing ulcer, an indolent ulcer. And then he was nice enough to send me the OCT, and so we'll watch that. Here's, sorry, the picture gets better. But he's got the amnion here, and it's about to fall off, but this just blows my mind here. So there's what it looks like clinically. Then he puts the OCT up here. And so the amnion's this real fine little line at the top. And what happens is this